Hi, I'm Dr. Shawn Panzer, and I'm with North Texas Gastrointestinal Associates, PA, located here in Denton, Texas. The address is 2501 Scripture Street, number 201, Denton, Texas, 76201. Phone number 940-566-4720. Fax number 940-566-4727. The website is www.ntgia.com. What I'd like to do today is give you a brief overview of cancer of the intestinal tract, and these are some of the most common cancers that develop in our country. When you look at our country compared to other ones, when you look at, let's say, like Europe and North America, we have higher risk of certain cancers in the intestinal tract as compared to areas where you don't have the same kind of Western diet that we have and the higher socioeconomic conditions that we enjoy. And so these are conditions that are real common. A doctor like myself is involved mostly in discovering these cancers, and then we pass on the care to oncologists such as medical and radiation oncologists, as well as surgeons who will hopefully be able to remove the tumor for a successful cure. So these are really common cancers, and I'm going to give you just kind of a brief overview of the different ones that we deal with in my specialty. So the first thing I want to do is just give you the normal anatomy. And so when you swallow, food goes over the tongue, and then it comes down this long tube called the esophagus. Your lungs are on either side, your heart's here, your windpipe's here. The food goes into the stomach where it mixes with acid. Muscles of the stomach grind up the food. It sits there a while, then goes into this C-shaped area called the duodenum. That area is important because you have two things emptying there. One is your pancreas running right here behind your stomach. It makes a juice that you need to break down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is the liver. It makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes through the pancreas and out to the intestine. Gallbladder is attached there and serves to store the bile until you eat, then squeezes the bile in to mix with the food. From there, goes down about 23 feet of small bowel, during which time nutrients are brought into the body, water and waste is left behind. That comes out in the right lower part of the belly in an area called the cecum. Your appendix is there. As your water and waste goes up your right colon, across the middle, down the left colon, and then makes this S-shaped turn to where it comes out. Water's removed and the stool becomes firm. Okay, so starting at the top with the esophagus, the esophageal cancer cancer has been with us quite some time, and in the past, the cancer that we dealt with was what's called squamous cell carcinoma. So the lining of your esophagus is like your skin, but without the hair, and so it was kind of your alcohol and tobacco cancer, and so less people are smoking than used to be the case, and so I don't think we see as much of that anymore. But it's a cancer that usually a person would get symptoms of swallowing difficulty, and you go in and you would find it, and it responds actually really well to radiation chemotherapy. I mean, I've seen some people that look like they were cured from this, and so it is a cancer that we don't see quite as much of as we used to, and usually it responds to that. Obviously, if it's gone outside of, like any other cancer, if it's gone into lymph nodes along the esophageal wall, or it's gone down to the liver, then you obviously cannot cure with surgery, and so usually you're going to be relying more on radiation and chemotherapy. The cancer that really is increasing is what's called esophageal adenocarcinoma. And if you've heard that term before, it's the same kind of cancer that you see with breast cancer or pancreatic cancer or colon cancer, and you can see it in the lung as well. And this is where the lining is more, it's coming from an intestinal type lining. And so what happens is that in about 10% of people who have acid reflux, the lining will change to what's called Barrett's esophagus. And Barrett's esophagus is a precancerous change. It's like a response to the acid conditions. And so in the past, or the acidic condition of the esophagus with reflux. And so in the past, Barrett's esophagus used to include a change in the lining to more of a stomach type lining, which is called gastric metaplasia. That no longer is considered to be precancerous. But if the lining becomes like your intestinal lining, that's an unstable, a genetically unstable state, and so people can go on to develop esophageal cancer, adenocarcinoma. And so it's thought that the risk used to be thought in the past. It was thought the risk of Barrett's esophagus becoming adenocarcinoma was higher than it really is. So it's about 0.1% per year. Now, if you develop what's called dysplasia, which is where you have an even more unusual, irregular-looking lining under the microscope, then the risk goes up. And so if you have low-grade dysplasia and high-grade dysplasia, then you're on your way to esophagus cancer, and the risk is much higher. And so obviously the best way to deal with this possibility is to address the Barrett's esophagus. So you would think, well, if you have Barrett's esophagus, why don't you just burn it off in everybody and prevent esophagus cancer? And technically that sounds like a good idea, but it just hasn't been proven to work. So right now the recommendations are to monitor the Barrett's esophagus endoscopically, and then if it starts to transform into low-grade dysplasia, high-grade dysplasia, that's when you start to think about burning that away. And so when you actually develop esophagus cancer, if it's a really early cancer just on the innermost layer, then you can actually remove that endoscopically. But most of the time when we find esophagus cancer, it's because someone has had trouble swallowing and they've had weight loss, and it's already out into through the wall. And the reason that can happen kind of earlier is because the lining or the esophageal wall does not have a wrapping, what we call a serosa. It has what's called adventitia. It's a loose kind of fibrous tissue, and so the cancer can easily get through that, get into the lymph nodes. And so usually when we find it, it's already in the lymph nodes, and it may even be in the liver, not resectable. And so you're looking at therapy, mainly chemotherapy, sometimes radiation therapy, depending on who's treating it. And when you get surgery, what has to be done is they have to remove this part of the esophagus and fill the space with something. Usually that's done by pulling the stomach up into the chest. That has a lot of problems. It creates a lot of problems because you lose the valve down here that controls the acid coming into the esophagus. You now have the stomach pulled up into this negative pressure environment, and so you tend to get a whole lot of reflux with that. But I've seen some people who are long-term survivors of it. Obviously, just like every other cancer, finding it early is important. If you have any kind of swallowing difficulty, you need to definitely report that to your primary care provider and see a gastroenterologist to get that evaluated. Obviously, I'm talking a lot about endoscopy diagnosing this. You need a tissue biopsy, but barium swallow will also show you a defect in the column of barium, and then you work it up subsequently. Another cancer, so that's the overview of esophageal cancer. The second type of cancer that we're going to talk about is gastric cancer, and so this is what you see here is what's called a gastric adenocarcinoma. This is the kind of the traditional gastric cancer, and this was a really common cancer in the 20th century, early 1900s. This was the most common cancer, if I remember right. I think that was the most common cancer at that time. What changed this was refrigeration, because up to that point, people were eating some partially spoiled food all the time, high bacterial content, a lot of toxins in there, and so that would cause problems with the stomach lining and lead to lots of DNA damage that generated the cancer. So adenocarcinoma is what you see here. Another type you can see is what's called a lymphoma, what's called a non-Hodgkin's lymphoma. A lot of times that's related, both of these are related to what's called Helicobacter pylori, which is an organism that can occupy the mucus layer just above the lining, causes chronic irritation, and in the form of infection where you develop what we call atrophic gastritis, you actually lose the ability to produce acid. The lining is basically thinned out, and then you get what's called intestinal metaplasia, which is where this lining becomes like the small bowel lining, just like I said with Barrett's esophagus. And this again is in that genetic transformation onto cancer. Unfortunately, the stomach has a lot of space, and so we usually don't find this until it's fairly far along, as far as with symptoms like weight loss and low blood count. You might throw up blood, but most of the time it's loss of a small amount over time. And so it again usually found when it's already out of the area, in lymph nodes, that kind of thing. But thankfully it's not very common nowadays. Only maybe about 25,000 cases per year. Again, radiation or chemotherapy is available, not very effective, very deadly cancer in this country. In other parts of the world, they actually screen for this. And so they tend to find it earlier, and there are endoscopic ways to remove it when it's an early cancer, and thus their survival rates are a lot better, but that's because they screen for that cancer and not for colon cancer. Then you move into the liver. The most common cancer we see there is what's called a hepatoma or hepatocellular carcinoma, and this is related usually to development of cirrhosis, as I said in the liver talk. And so you get the scar tissue laid down. It's usually chronic inflammation that's been going on for years. Chemicals are released by the white cells. You might have direct toxin effects from various things, including alcohol. And so once you develop, usually that's the same issue, that either you're fortunate if we can find it incidentally. So in other words, you get a CAT scan for another reason, you get an ultrasound for another reason, or they're screening like we do when people have cirrhosis or certain forms of liver disease. That's the setting that you can actually find it and cure it. There are a lot of different ways to, of course you have the different ways of diagnosing the cancer. You have your initial radiology studies. Usually you're going to proceed, you're going to get a tumor marker called alpha-fetoprotein, look for that, and then there's usually going to be some sampling involved, usually by radiologists, and that's how you get your diagnosis. From there it goes on to treatment. Depending on the size, you can resect it. Sometimes if you have cirrhosis, you can't do that because you don't have enough normal liver left behind. So in some cases they'll consider liver transplant, but there are very specific criteria, like you have to have less than, I think, a total tumor volume of 10 centimeters in doing that, and there's some other things that go into it. So again, a tumor that I usually don't see at an early stage. Usually it's already fairly advanced by the time, but in some of the more in the tertiary type centers, you may catch it early. You can do you can ablate the tumors with alcohol injection, ironically. You can do radiofrequency ablation. So a lot of different techniques that are applied by radiologists, surgeons, and then of course you have your usual chemotherapy if it's an advanced situation. Biliary tumors, there's one called cholangiocarcinoma, which typically occurs right where the bile ducts branch into the liver. It is usually, it can be related to your usual abuse of substances. It's also seen in what's called primary sclerosing cholangitis, which is a situation where the immune system attacks the large bile ducts. And usually it's found at an advanced stage. Where I trained at Johns Hopkins, there were some surgeons who were real good at treating this. But at that time, it was really a nasty treatment. Involved tubes coming out of the skin to drain the biliary tree, and then it's a big surgery to get that. And like with all these other things, surgery is the preferred way because you just want to get the thing out of there. But if it's already gotten into lymph nodes, it's already into local blood vessels in the area, not as addressable, and usually you're dealing with radiation and chemotherapy to deal with that. Gallbladder cancer, again, really is actually a rare cancer. I've not seen anybody, I don't know if I've seen anybody with that in the 22 years I've been practicing. But it's usually seen in relation to gallstones. It can be seen in what's called porcelain gallbladder. That's been disputed recently. The most important thing about gallbladder cancer is if you have gallbladder polyps, I feel like you should get your gallbladder removed. There is another school of thought that you can monitor with ultrasound every 6 months, and if the polyps start to increase in size, then you can get it removed. I don't think that's such a good idea. So I don't like that one. But I'd let the surgeons decide that. Obviously, it's the same kind of thing. Surgery is the best way. If you have lymph nodes involved, you're not going to do as well. And then, of course, chemotherapy is not very effective for that either. Then you get into pancreas cancer. Pancreas cancer is the fifth leading cancer cause of cancer death in this country, and it's a very deadly cancer. I mean, 95% of people will die within 5 years, and the current medications, chemotherapy drugs, give you additional months, but long-term survival is very rare. The key thing is try to find it early. Usually you're going to find it early if it's an incidental finding, imaging done for other reasons, and it is sometimes if you're lucky, it'll be small and it will push on the bile duct and make you yellow early on, and that gives you a better chance of surgical resection. The biggest problem with, of course, the best chance of cure, really the only chance of cure is surgery. Only about 25% of people with pancreas cancer will have will be resectable by surgery based on preoperative imaging and studies, endoscopic ultrasound being one of those. And then when they get in to do the surgery, only about 25% of the time is the tumor resectable, because it involves more of the, because the preoperative studies understage the tumor. It's actually involving the vessels more significantly, or it's just not possible to get it all. And so if the surgery is done, it's what's called a Whipple's procedure. And basically everything that you see in this area here has to be reimplanted. So your bile duct, stomach has to be drained, pancreas has to be drained, the bile duct, as I said, and it's a big surgery. So if you can survive the surgery, then you got the post-operative period, which is usually bad, usually very bumpy, difficult. Usually people with pancreas cancer are older, they've got other medical problems, and so you really got to give some thought to whether or not you want to go through that, because the vast majority of people are going to pass away anyway. So you have to individualize care, and I think everybody has to make that decision for themselves. But it is a brutal surgery. Then when you get into the small bowel, so remarkable, small bowel almost never gets cancer. I've seen a couple people get what's called the adenocarcinoma related to celiac sprue, where you get allergic to wheat. Lymphoma can be seen in particularly when you have Crohn's disease, and also adenocarcinoma can be seen related to that as well. But it's actually really uncommon. Probably one of the more common things you see is actually metastasis from other places. Melanoma is a tumor that for some odd reason goes to the small bowel, but you can see it also with small cell carcinoma of the lung. So, and that's something you have to think about all the time, is that when you have growths and you find in the liver, you got to think about it being something that came from elsewhere, not only a tumor that started in the intestinal tract. So again, usually don't see a lot of this, the problems in the small bowel, which then brings us down to the colon. Colon cancer, which you see in these three locations here, is really common in this country. It's the second leading cancer killer after lung cancer. It affects about 6% of our population. So because of that, it's one of the cancers that we look for in everybody, including cervical and breast cancer in women, and then prostate cancer in men. It affects about 6% of our population. One of the most important factors in colon cancer is family history. And so when you have an immediate family member who has colon cancer, there's about a 6% increase in risk for each family member involved. Second-degree relatives like your grandparents, first cousins, that kind of thing, increase the risk, but nowadays we really don't count that the same way. We generally feel that unless you have multiple family members and they were younger, the second-degree relatives don't count so much anymore. So, very common problem. The second thing about colon cancer is that it doesn't just arise out of thin air. It goes through a stage called a colon polyp. This is a benign growth that can become colon cancer, but doesn't always do that. However, every colon cancer starts off as some form of growth. And really, you can really pretty much say that about the entire intestinal tract. We know that in the pancreas, you can develop what are called IPMNs. And these are basically like polyps that you see before you get pancreas cancer. And so that's something that in the future we might be able to target more specifically and catch some things earlier. But it goes through this stage before it ultimately goes into cancer, and that almost certainly is related to genetic changes that are accumulating in the individual cell that started the cancer. So anyway, so every polyp, everything starts off as some kind of growth. And so certain conditions make this more likely. For example, inflammatory bowel disease like ulcerative colitis and Crohn's disease, where you have chronic inflammation, will set you up for colon cancer. And so for example, when you look at people who have ulcerative colitis, if they have involvement of the entire colon, and they have the length of disease that exceeds around 8 to 10 years, then we know that a person has about a 10% chance per decade of developing colon cancer. And again, I gave you the numbers on family history. The best way to deal with colon cancer is to get a colonoscopy, is to get screened for colon growths. And so we can go in, we can cut these polyps out, and that prevents colon cancer. But you don't get symptoms with colon polyps. Generally speaking, you get symptoms from growths in the colon because they outgrow the blood supply. So you start seeing blood in the stool, change in bowel habits. If the tumor is growing like this one, creating this apple core type appearance, then the bowel movement will be thin and will change in shape. Obviously weight loss is an advanced symptom, and so you really have to get screened. That's the key thing with colon cancer. And so in this country, we start looking at age 50 for the low risk people. If you're high risk, we look at age 40 or 10 years earlier than the age of diagnosis of the affected person in your family. If you have multiple family members involved, they had tumors at a young age, then we start even looking for genetic conditions that predispose you to colon cancer. And so if you have what's called familial polyposis, the screening starts at age 10. If you have what's called Lynch syndrome, the screening starts at around age 20. And so that's really the key thing. Once you develop colon cancer, then the best chance of cure is surgery. And luckily, with surgery, probably 75% of people are cured. Many times, if the tumor has, and this is definitely true, if the tumor has extended into the wall or into lymph nodes, you're going to get some additional therapy, such as chemotherapy. In rectal cancer, where it's low down here, then many times you're going to get radiation and chemotherapy ahead of time to shrink it down and make it more surgically resectable. But obviously, when you get down into the rectal area, then you're starting to run a higher risk of requiring a permanent colostomy because they can't physically make the connection. You can't get good enough margins. But for the key thing is to get your screening done. Some people argue that we should start at age 45. That has not become the standard yet, but that's being discussed in the literature. As I said a minute ago, when you look at your treatment, your surgery is your best option. If you have tumor removed up here, unless you are already blocked up, then you will usually avoid requiring a colostomy. But if you come in and the colon is totally blocked up, then you run the risk of getting colostomy because the bowel that's in front of the blockage is dilated, the bowel below it is compressed, and the surgeon can't bring the two ends together. So usually you'll get a colostomy, they'll close off the lower part, wait about 6 weeks, and then go back and make your attachment. Down in the rectum, again, you usually will get a combination of radiation and chemotherapy. Up here, usually the chemotherapy would be decided by the staging by the pathologist. If you already have metastases to the liver, then you're dealing with chemotherapy. They may still do surgery to eliminate possibility of a blockage, but a gastroenterologist can also go in and put stents across blockages to keep that open if it's obviously a very advanced situation and it's thought that you have less than 6 months to live. If you have one metastasis to the liver or maybe a couple, sometimes they'll go ahead and just cut those out as well and go for a cure essentially. So this is kind of an overview of colon cancer. Finally, you can also have what's called anal cancer, and that's obviously coming from the anal canal. And that lining that generates it is the squamous cancers or squamous tissue, what's called squamous cell carcinoma. And this is usually related to human papillomavirus, but most of the time you are not looking at surgical resection. Usually surgeons are involved in diagnosis, but usually dealing more with radiation and possibly chemotherapy in that area. One of the problems with the rectal cancer, just to say one other thing, is that it tends to recur locally more commonly than when you see other parts, cancer in other areas and of the colon. And so surveillance down in that area, it's probably it'd be a good idea to make that a little more frequent. Also, radiation therapy to the rectum through prostate cancer treatment also increases the risk of colon cancer in this area, and rectal cancer, in other words. So it's something that I look for in terms of the history. Then you have some other unusual tumors that occur. You can get what's called a mucocele, which is a type of appendix cancer. And this is usually we've discovered this incidentally, either by CAT scan because the appendix is thickened, or when I go in with endoscopy and I come around, I see the opening here. It looks like there's mucus coming out of there. I usually follow that with a CAT scan. Sometimes the appendix will be making an impression on the first part of the colon, and that can also be another suggestion. So that concludes the overview on gastrointestinal cancer. Obviously, it's a huge, expansive topic, and something that I'll come back to in future videos on an individual basis when I see something in the literature that is very suggestive. It's suggestive of some breakthrough and what have you. And again, main thing that you should do in regards to any cancer is get the screening done that you're supposed to get done. Get it done when you're supposed to get it done. Don't be afraid of a colonoscopy in the prep and this kind of thing, because it's just not a it's a pain, but the pain of going through cancer treatment is way worse than any diagnostic test, screening type test you can possibly go through. And so, it's estimated that, let's say, just with colon cancer, only about 62% of people with colon cancer have been screened, who should be screened. It used to be about 50%. It's now 62%. And so we have a long way to go still. And these are tests that your insurance will pay for. And I also want to say one other thing about some of the stool-based testing. A lot of the primary care doctors are turning to what's called Cologuard, which is a test that looks for blood in the stool, which is actually the best part of that test. And then it also looks for genetic changes, basically markers in tumor cells that are shed into the stool. And so the tests are good for diagnosing an established cancer. They are not good for finding polyps. And so when recommendations come out from the government in terms of the screening guidelines regarding colon cancer, colonoscopy stands alone as being the tier 1 recommendation because it's the most accurate, and it also allows us to do things while we're there. When you look at the stool-based test, they're good for finding cancer, as I said, but when you look at their accuracy when it comes to finding polyps, it's dismal. I mean, it can be like 6 to 10%, and so it's not a substitute. And again, if someone is not going to get colonoscopy done, that's when you start looking at these other approaches, whether you're talking about virtual colonoscopy or you're talking about the Cologuard or tests like that. And so that's again, those are what are called second-tier recommendations. So again, don't be afraid of screening. It's important you get it done. And all these cancers I talked about are better. It's better when you find them when they're early on. So if you start getting symptoms, trouble swallowing, if you throw up blood, obviously, if you have any unexpected weight loss, these things, get these symptoms checked out quickly, because again, it's a lot better to find them early than to wait and hope for the best. And again, this is the most important message I can leave with you. So I hope this helped. Again, this is not a video about treatment. It's about diagnosis, which is what I deal with. And if I can be of help in seeing you, then I'd love the opportunity to do so. Hopefully, if you see other people, you can ask better questions and be a better consumer of your healthcare dollar. Thank you. Hi, I'm Shawn Panzer, and I'd just like to take a few minutes just to let you know about some of the different things that we offer through my office. Obviously, I'm a traditionally trained gastroenterologist from Baylor College of Medicine in Houston and Johns Hopkins up in Baltimore. But obviously, things change over time, and so I think it's important that a person also get kind of keep up with the times and be contemporary. And you also want to balance that with things that have worked from the past, because a lot of times things come up that are that seem to be awesome and something you want to put in your practice right away. But a lot of times you need the kind of the percolation of time to make sure that the procedure is truly safe and is one that's going to benefit a patient. And that does take a combination of experience and knowledge of the literature and other things. So I just want to make you aware of some other things that we do. Of course, you can obviously see me in the office, kind of the traditional way, but I also have telemedicine, which allows a person to have an office visit, a follow-up office visit over Google Duo or the iPhone FaceTime. And I can't do new patient visits that way, but it is covered by insurance and Medicare. And I use that a lot in people who have to drive or can't get here easily, or off in other places like in school, that kind of thing. We also have a nurse practitioner named Tony Perkins. She's sees patients while I'm here in the office, and her practice is mostly focused on helping people who need to be worked in that cannot be seen, cannot be worked into my schedule. And so she's also available. We also do in-office hemorrhoid banding with a system called the CRH O'Regan system. And this is kind of the latest version of hemorrhoid banding. I've done hemorrhoid banding since I read about it, the endoscopic version in 1996. But this newest version is basically a painless version that does not require colon preparation. I can do it right here in my office, again covered by by Medicare and also by private insurance. We also have a type of radiology device that's called FibroScan. This allows us to quantitate, not only it uses an ultrasound technology which allows us to quantitate how much fat is in the liver, and it also allows us to tell liver stiffness, which correlates to how much scar tissue is in the liver. So if you have a chronic liver problem such as hepatitis C or fatty liver, then we can use this to, in a non-invasive way, to give us an idea of how much scar tissue you have. This may lead to a change in your management, either through medical management or to referral to a tertiary level medical center slash liver institute for more for access to possibly clinical trials and other things. But in the past, the only way we could do that was with liver biopsy. You can also get similar information from an MRI, but MRIs are very expensive and it's very difficult to do a good MRI. The last thing I want to talk about is an alternative medication line that we're developing for digestive diseases. And the alternative medications are it's a big industry. There are a lot of people that carry the medications, drug stores, grocery stores, and all that. And there are just so many different products and so many different things out there, and it's just kind of mind-boggling, really. The unfortunate thing with a lot of those, for the vast majority of these supplements and minerals and herbs and these things, is that there's just no clinical data. So a doctor like me who prescribes your standard prescription medications, all of those had to go through scientific studies in which they were compared to placebo. They went through animal trials. They went through patient trials. And then a lot of times we have years of experience with these. And so we know that they work better than a placebo. But a lot of people are turned off by big pharma and the expense and just the suspicion that the medicines are not good for them, side effects, this kind of thing. When you turn to alternative medications, you have even a worse problem because you have so many different chemicals that are put into one product. You don't know which one works. You don't know which one may be interacting with medicines you're already on, that kind of thing. But people seek that care a lot and go to non-traditionally trained individuals and put a lot of trust into people that have not spent a lot of time either practicing medicine or studying medicine. And so what I'm trying to do over the last year is educate myself more about the things that are out there, try to get as much information as I can, scientific information, to help me make decisions as to what may work and what may not, and what does not work. And so that's what I've been trying to do is we're putting together a product line that will allow us to treat the things that we see. And so we're going to use these as a combination with the traditional medications, and hopefully we'll get better results as a result of that. These medicines will be available in the office. They're also going to be available online on an eBay store as well. And so please give them a look. And obviously when you come to the office, I'll definitely describe those. But again, the idea is to get some kind of a product line that I can feel good about in terms of the production and also standardization, and where we can combine it in a controlled way as compared to just going out and taking a handful of different supplements that may be countering each other or just not doing anything for you and wasting your money. The last thing I'd like to talk to you about is hydrogen breath testing. This is technology which allows us to measure how much hydrogen you're exhaling, and our bodies don't make hydrogen, only bacteria do. And so what this allows us to do is to look to see whether or not you are possibly malabsorbing different things, such as lactose and lactose intolerance, fructose intolerance, and also what's called SIBO, which is known as small intestinal bacterial overgrowth. It's a condition in which you have bacteria in your small bowel which should not be there, and in too high quantities, and as a result they are interfering with the function of the bile and also the digestive juice made by the pancreas and by your small bowel lining. When that happens, then you don't absorb things the way, digest and absorb things the way you're supposed to. They go lower in the bowel where they're broken down by bacteria, and that's fermentation, and that can lead to anything from gas and bloating all the way to diarrhea and even weight loss. So it's something that's part of our workup of symptoms like gas, diarrhea, and bloating. So we're, like I said, we have these available now. We're always looking to add things I think are going to be helpful. These things are covered by insurance, and with the exception of the supplements. And I hope you give these things a look. Thanks for your time.